Welcome back to part 96 of our 100-part CPC exam series. Today, we are officially moving past basic anatomy and stepping right into the heavily rule-bound reality of compliance, regulations, and reimbursement. Let's jump right in and make sure to like, share, and subscribe to Decode Healthcare with Harshal.
All right, quick look at today's agenda. We're building your cognitive roadmap with 4 stops: a compliance overview, an NCCI edits masterclass, global surgical package rules, and finally, fraud versus abuse. Let's get to it. Starting off with Section 1, Compliance and Reimbursement Overview.
Now, you might be wondering, why do these rules even matter? Look, coding isn't just about slapping numbers onto a chart. It's absolutely crucial for justifying medical necessity, securing accurate reimbursement, and, maybe most importantly, preventing massive audit risks by strictly adhering to payer edits. So, what does compliance actually mean for you on a daily basis? It's the strict adherence to federal statutes, payer guidelines, and documentation standards to stop improper payments in their tracks. And hey, always remember the coder's golden rule. If it isn't documented, well, it literally didn't happen.
Moving right along to Section 2, our NCCI Edits Masterclass.
Okay, so the National Correct Coding Initiative, or NCCI, was developed by CMS specifically to stop improper unbundling. They structure these rules using procedure-to-procedure, or PTP edits. You've got Column 1, which is your comprehensive code, and Column 2, your component code. Usually, those Column 2 codes are bundled straight into the major Column 1 procedure unless some very distinct circumstances apply.
To navigate those edits, you've got to understand NCCI modifier indicators. Think of this as your ultimate visual cheat sheet. A 0 indicator, that means unbundling is literally never allowed, no exceptions. But a 1 means you actually can bypass the edit, but only if your clinical documentation firmly supports a distinct, separate service. And a 9 just means the edit was deleted or retired, so you don't really have to worry about it. So how exactly do we bypass a 1 indicator? Modifiers. We see modifier 59 used a lot for a distinct procedural service. But keep in mind, Medicare really prefers those highly specific X modifiers. XE for separate encounter, XS for separate structure, XP for separate practitioner, and XU for an unusual non-overlapping service. Bottom line though, your documentation must explicitly back up the distinct nature of the service if you're going to use these safely.
All right, shifting gears to Section 3, Global Surgical Package Rules.
This whole concept exists to prevent fragmented billing. It bundles routine, expected care into one single surgical code. These global periods are classified strictly by procedure severity. So a 0-day period is for minor or endoscopic procedures. A 10-day period is for minor procedures that have a short recovery. And those 90-day periods, those are reserved for major surgical procedures. Basically, the severity completely dictates the post-operative bundling timeframe.
You have to know exactly what is included versus what's excluded here. Routine post-op care and intraoperative services, those are bundled and included. But what about excluded services? That would be something like a totally unrelated E&M visit or an unplanned return to the operating room to fix a completely distinct complication. Which brings us to 2 heavily tested EM modifiers. You will definitely see these on the exam. Modifier 24 is used for an unrelated EM visit during a post-op period. On the flip side, modifier 25 is used for a significant, separately identifiable EM service that happens on the exact same day as a minor procedure. Keep those 2 straight in your head. Let's rapid fire through some more critical surgical modifiers to lock them into your memory. Modifier 78 is for an unplanned related return to the OR. Modifier 79, that's for a completely unrelated procedure by the same physician. And if patient care is split up among different physicians, you'll use 54 for surgical care only, 55 for postoperative management, and 56 for preoperative management.
Zooming out a bit now for Section 4, Fraud versus Abuse and Key Federal Statutes.
Listen, fraud and abuse are fundamentally different, and you need to know the difference. Fraud is an intentional deception, like purposely billing for services you absolutely never rendered just to gain an unauthorized benefit. Abuse, however, involves practices that are just inconsistent with sound medical or fiscal practices, which end up resulting in unnecessary costs. Intent is the big dividing line here. It's a real game changer. Here are the big 3 federal statutes you absolutely must know. First, the False Claims Act, which prohibits knowingly submitting false claims to the government. Second, the Anti-Kickback Statute, which criminalizes exchanging any sort of remuneration or payment for referrals. And third, the Stark Law, which prohibits physicians' self-referral for designated health services. Seriously, ignorance of these laws will never protect you or your facility from severe penalties.
And that brings us to Section 5, Explainer Summary and Teaser.
Go ahead and take a screenshot of this dense visual summary cheat sheet right now. It covers your NCCI indicators, your 0, 10, and 90-day global periods, those tricky surgical modifiers, and the definitions of fraud versus abuse. Mastering these specific constraints isn't just helpful, it is the absolute key to passing your CPC exam. Think about this. Just one innocent coding error can trigger a massive federal audit. That's why mastering these rules is so vital to your career. If a federal auditor knocked on your clinic's door tomorrow morning, would your documentation actually survive the test? Next time, in Part 97, we'll secure your defenses as we dive into HIPAA, ABN rules, and the OIG's 7 compliance elements. Keep studying hard, and I will see you in the next explainer.